Okay, self-assessment of this chapter, chapter 12, the patient with anxiety, fear or avoidance. 21-year-old student calls an ambulance for fourth time in a month because of chest pain, shortness of breath, and a feeling she's about to die. This settles by the time she reaches the accident and emergency department. On all occasions, her examination, electrocardiogram, and cardiac enzymes are normal. She has her final exams in a fortnight and admits she is very worried. What is the most likely diagnosis? So, acute coronary syndrome, thyrotoxicosis, hypoglycemia, panic attack, or asthma. Of course, we are talking about panic attack. This is the most likely diagnosis based on the history. However, it's important to take a full medical history for asthma, congenital heart disease, and so on, and of course with family history of sudden death in young relatives, and to exclude other causes such as hyperthyroidism and hypoglycemia. Okay, and of course because of the rapidity of the symptoms, you would also investigate if there is any triggers like substances or something. Okay. Another question. A 57-year-old obese man keeps calling appointments with the practice nurse to have bloods taken for cholesterol and glucose. Although he is normally very cheerful and relaxed, he becomes pale, sweaty, and tremulous when you offer to take his bloods during the consultation. What's the most likely diagnosis? A. Myocardial infarction. B. Hyperglycemia. C. Blood injection injury phobia. D. Panic attack. Or hypochondriasis. So we are talking about C. Blood injection injury phobia. This is suggested by his situational paroxysmal anxiety and avoidance of that. And all of these are about this blood and injection thing. Myocardial infarction is unlikely to occur every time he is due to see the practice nurse. Hyperglycemia cannot do this. Hypoglycemia maybe, but it's unlikely without a history of diabetes, of course. Panic attack, when we are talking about panic disorders, panic attacks in panic disorders usually have don't have actually specific triggers like in this case. Okay, and it's not hypochondriasis, it's not about any illness or something. 63-year-old woman with a history of depression presents to the accident and emergency department and tells you she has a dry mouth, a choking sensation, butterflies in her stomach, palpitations, and shortness of breath. She tells you she had some bad news recently. What's the most appropriate first step in management? A. ECG. B. ABC, airway, breathing, circulation. C. Psychiatry referral. D. Bloods, full blood count, urea and electrolytes, liver function test, and troponin. E. Arterial blood gases. Okay. Of course, we need to do the ABCs first. Okay, so that's the first step in management, ABC. But of course, because she's speaking to you, so her airway is maintained independently. The next step is to ascertain her breathing and circulation status. Of course, the differential includes panic attack, but she also need to because she is experiencing a wide range of acute medical problems that may require urgent management, so we need to rule out any other cause. So ECG, ABG, psychiatry referral, all of these would be appropriate according to the case. A 24-year-old man who was recently diagnosed with type 1 diabetes attends his general practitioner. Over the last month, he has experienced recurrent attacks of anxiety associated with sweating, tachycardia. The episodes do not seem to have any triggers, last for about 20 minutes, and resolve when he sits down with his girlfriend and has a cup of tea and biscuit. What should the GP advise the patient to do next time it happens? Deep breathing exercises, note it in a diary, take diazepam, see a counselor, check blood sugar. Of course, check blood sugar. Here we have, someone with type 1 diabetes. And the description sounds very much like hypoglycemia. So if hypoglycemia is confirmed, it is important to treat the episode by consuming carbohydrate. That's what happened actually with the patient previously. And of course, we need to examine his insulin food activity regimen to reduce further episodes and to manage that. But if his blood sugars are normal, he may be experiencing panic attacks as part of panic disorder. Maybe that's the case. So that's it. Okay. Another question. 44-year-old businessman presents to his general practitioner because of the last month he has felt anxious, sweaty, and shaky in the mornings. He feels better when he has lunch and generally his mood is good. He admits to drinking a bottle of red wine every night and usually having champagne during business lunches. What's the most likely diagnosis? Depressive episode, diabetes, panic disorder, alcohol withdrawal, or work phobia? So we are talking here about alcohol withdrawal, of course. So this man is drinking at least 60 units per week. According to this, he's having, a bottle of red wine every night with champagne. So he's experiencing pathological, physiological withdrawal symptoms after a few hours without alcohol, which would be in the morning. And the symptoms are relieved by further alcohol in lunch. So, okay. So let's go to some extended matching questions. So here we have some differential diagnosis for anxiety, fear, or avoidance. Agoraphobia with panic disorder, agoraphobia without panic disorder, social phobia, generalized anxiety disorder, panic disorder, depressive episode, acute stress reaction, post-traumatic stress disorder, adjustment disorder, personality disorder, anxiety secondary to general medical condition or secondary to psychoactive substance use. So for each of the following patients, select one most likely diagnosis from the list above. First, a 25-year-old librarian avoids being with others whenever possible. He does all his shopping online and always volunteer to reshelves books rather than deal with inquiries. When he is forced to interact with people, he can feel himself blushing and sweating. He feels they are scrutinizing and judging him critically, even though he knows he is not really a bad person. So here we are talking about social phobia, of course, because this man has these symptoms of avoidance of social situations and marked anxiety and distress when in these social situations. Another case, a 43-year-old woman feels she has been on edge for 2 years. She spends most of each day worrying about many trivial topics, and sometimes she feels something bad is going to happen for no reason. She lies awake at night thinking about these things. She often has a dry mouth, epigastric discomfort, and bilateral frontal headache. Okay, here we are talking about generalized anxiety disorder because this lady has experienced continuous anxiety and apprehension about minor matters. These matters are associated with autonomic overactivity and muscle tension for over than 6 months. So we are talking about generalized anxiety disorder. 28-year-old secretary presents to her general practitioner with weight loss. 6 months ago in a supermarket, she suddenly felt like she was going to die. She had pain in her chest, was short of breath, and her arms and lips tingled. She rushed outside and the feeling subsided. But now she does not like to go into any large shops and is eating less well. She is still going to work, but now walks 5 miles each way as she does not want to be on a bus and have another attack. As long as she is in her house or with her friends, she is relaxed. So the patient here has agoraphobia with panic disorder, of course. She has a panic attack in a supermarket and has now become increasingly avoidant of crowding and confinement. Her symptoms are restricted to these situations, and the weight loss may well be explained by her reduced dietary intake and the increased exercise that's caused by these symptoms. Okay, but anyways, you may check for other disorders, of course. Over the last 3 months, a 35-year-old builder has experienced several episodes of sudden onset shortness of breath, palpitations, sweatiness, nausea, feeling that the world is unreal, and feeling he is about to die. These feelings resolve spontaneously over 20 minutes. He cannot identify any triggers. In particular, they are not brought on by exercise, and he can continue to do his active job. His ECG is normal. Of course, here we are talking about panic disorder. Okay. Another case, 37-year-old professional violinist finds himself unable to play concerts. He can play well when alone, but starts to sweat and shake such that he cannot play properly when in the presence of others. He has had to cancel a tour. These symptoms came on after he received a series of negative reviews. In general, he is a relaxed person who enjoys socializing. So, here we are talking about performance anxiety. It's a type of social phobia, but specific in something, okay? Okay. "42-year-old policeman has experienced low mood, anhedonia, fatigue, early morning awakening, and anorexia for the last month. He has free-floating anxiety most of the time and has had 2 panic attacks. These symptoms had onset after he witnessed an armed robbery, but he denies flashbacks and still buys milk in the shop where he witnessed the robbery." So the patient here has depression, actually. He has the 3 symptoms of depression and 2 further biological symptoms. So low mood, fatigability, and anhedonia, with problems in sleep and and appetite. So and without any okay. So this is depression. And his anxiety symptoms are concurrent with his depression, so the primary diagnosis is of a depressive disorder rather than an anxiety disorder. Although his symptoms had onset following a traumatic event, they are too prolonged to be an acute stress reaction, of course, and so severe to be an adjustment disorder. And he denies 2 of the 3 basic symptoms of post-traumatic stress disorder: no flashbacks, no hyperarousal. So we are talking about depression. Another question: anxiety secondary to general medical condition or psychoactive substance use. Here we have the causes: Cushing, hypoglycemia, hypothyroidism, pheochromocytoma, caffeine, alcohol, cannabis, amphetamine, fluoxetine, mirtazapine, and trazodone. For each of the following patients, select one most likely cause from the options above. A 63-year-old shopkeeper with hypertension has periodic episodes of anxiety, tachycardia, sweating, and pallor. She can identify no triggers but recalls her mother having a similar problem. Her random glucose is elevated. So here we are talking about pheochromocytoma, of course. But because of its rarity, I would say, this remains unlikely. The unlikely diagnosis of this scenario. But it is the most likely from the options that are given. The features suggestive of pheochromocytoma are family history, because she has family history. She remembers that her mother having a similar problem. She has hypertension, symptoms of hyperglycemia actually, and intermittent episodes of increased catecholamine release, which is known by these symptoms of anxiety, tachycardia, sweating, and pallor. And of course, the history alone is not diagnostic, so you need to do urinary or serum catecholamine assays and imaging for adrenal glands. Okay. 48-year-old scientist with a past medical history of vitiligo presents with a 3-month history of anxiety, increased appetite, and heat intolerance. Her hands are shaky and she has knocked over a lot of test tubes recently. Okay. Vitiligo, anxiety, appetite, increase in appetite, heat intolerance. Okay, so we are talking about hyperthyroidism. Okay, so what about vitiligo? What it has to do with this? Okay, vitiligo is an autoimmune disorder which increases the risk for another autoimmune disorder like Graves' disease here. Tremors, heat intolerance, anxiety, increased appetite, all of these are classical symptoms of hyperthyroidism. Okay, a 25-year-old junior has recently been diagnosed with depression and commenced an antidepressant 4 days ago. Since then, he has been very restless and agitated and frequently called his friends for reassurance. His sleep has worsened further. I would say fluoxetine would be the cause here, because SSRIs generally, especially fluoxetine, can initially be alerting and agitating actually, particularly in young adults. And that would explain actually the increased incidence of suicide in severely depressed patients, and that's why we need close monitoring for them at the beginning of the treatment at least. So, a 23-year-old man has started a new job as a welder. He has noticed that he gets very irritable and anxious by the end of the day and has had to go home early a couple of times. He sweats a lot while working, so is drinking a lot of his favorite soft drink. Go man. Okay. It's obvious actually. We are talking about caffeine toxicity or intoxication, because caffeine has anxiogenic effects. And many soft drinks, and from this name I would say this is something, energy drink or something, it has a lot of caffeine. So that would be the answer. A 19-year-old man is brought to accident and emergency by his friends. He is pacing the cubicle, is tachycardic, hyperventilating, sweating, and has dilated pupils. He jumps when his name is called. His friends saw him swallow a white tablet earlier in the evening. So we are talking about stimulants. The option was amphetamine here in the question. So that drug increases concentration and sympathetic activity. And cocaine would do the same similar presentation, but usually cocaine is sniffed or smoked. It's not taken as tablets usually. So that's it.